Good afternoon. Good afternoon to each one of all. Thank you very much for taking your time to attend the scientific session. Welcome you all to the knowledge-driven experience sharing IPC Masterclass 6.0 presented by SANMED. After a resounding success of our earlier 5 series and with the encouragement from all our healthcare professionals, now we are presenting IPC Masterclass 6, which is again all-encompassing. Particularly, this topic is going to be on surgical site infection. From beyond incision, what are all the measures which can be taken for preventing hospital-acquired infection, particularly surgical site infections. We at SANMED strongly believe that sharing knowledge and spreading awareness will greatly help in improving the health of patients, more so in preventing and reducing healthcare-associated infection. Our vision is always to protect patients, personals, and products throughout the world against infection and contamination and become a global partner in infection control and patient safety. In line with our mission, we would like to conduct this program in association with Infection Control Academy of India and University of Hyderabad. And we will also bring in people of different expertise from different specialties and different origins so that they'll share their experience and also become handy in your day-to-day practice to use them and have a better patient safety. So our mission is to offer a wide range of high-quality antiseptic and disinfectant products at a competitive price globally. We believe in adding value to our stakeholders through dissemination of knowledge, innovation, and continuous improvement. SANMED is a leader in IPC industry for giving market direction, spreading awareness, and knowledge dissemination. Thank you very much for all of you once again for joining IPC Masterclass 6. We at SANMED is always at the forefront of giving you knowledge dissemination advantage and also sharing the latest updates in the area of IPC. Once again, we thank IFCAI and University of Hyderabad for joining hands for this wonderful program, IPC Masterclass 6.0. This topic is going to be extensively managed, and the first session, we welcome Dr. Ratnamani. She is quite a familiar name in the specialty, and Madam needs no introduction, but still it's our duty to introduce her. And this session is being chaired by Dr. Ranga Reddy, and he'll also be joining in a moment now. So Dr. Ratnamani is a very well-known faculty in microbiology area, and she is associated with Apollo Hospital, and she's trained and a well-qualified doctor in the area of microbiology, and he has done her PG diploma and also AMBH from ISB Institute of and CSC from CBIEC, and she's a trained medical mycology and mycology at PGI Chandigarh and also with WHO collaboration. She heads microbiology and director in lab services in Apollo Hospital, Hyderabad, and she heads the infection control program of Apollo Hospital, Telangana region, and has a very handsome experience of 21 years of experience in the management of in microbiology area, and she has done Lean Six Sigma Green Belt and participated in JCI and NABH accreditation of Apollo Hospital, and she has also participated in various research programs. So she contributed chapter on surgical site infection in Pulmonology and have national and international publications. So, and I request Madam, thank you very much, Madam, for your taking out your time and sharing your experience and knowledge with all the fellow colleagues so that they will also get benefited in preventing surgical site infections. Thank you so much, Madam. The session is handed over to you. Thank you so much, Madam.
Thank you so much. Thank you for the kind introduction. And at the outset, let me thank the organizers, Dr. Ranga Reddy, for giving me this opportunity to be a part of this IPC Masterclass. Give me a few seconds. I will just be sharing my screen. And let me restart again. So at the outset, I thank Dr. Ranga Reddy and SANMED and the organizing committee for giving me this opportunity to be a part of this SSI prevention IPC class. So my talk is on pre-operative interventions for the prevention of surgical site infections. So this IPC class for prevention of SSI is divided into three: pre-surgical, that is before the surgery happens, then during the surgery, and post-surgery. So my talk is going to be exclusively on pre-operative interventions. Next. Next, please. Yeah. So if most of you might know that this person, Ignaz Semmelweis, is the one who actually revolutionized the concept of infection control. 200 years later, we still talk about the significant aspect hand hygiene plays in prevention of infection. So the infection control has evolved over a period of time. It's not a new concept, but its importance is being understood as we are advancing into the newer technologies. And I think COVID was another thing which was a wake-up call for all of us, which made us understand the importance of infection control. And a very important part of healthcare associated infections, other than the VAP, CLBSA, COTI, is the prevention of surgical site infections. Next. Next, please. Can I have next slide, please? Yeah. So surgical site infections lead to increased morbidity, mortality, length of stay, and it's also huge cost for a patient. And it is imperative that we understand that what are the various risk factors and what are the preventive measures which we should have compliance with to prevent or at least decrease the infections in these patients. And there has to be a collaboration between the staff. That can be OT staff, it includes surgeons, housekeeping, perfusionists, technicians, as well anesthetists, as well as the infection control team. Next, please. Okay, I know this is a different picture which is depicting a lion and a man. Now you can decide who is the ICP and who is the surgeon. I'm an infection control practitioner, so I think I will consider myself a lion. The other person can also think that they are the lion, maybe the other side. So it's very difficult to merge both the surgeons and the infection control practitioner, but there is a way. And only by having a good collaboration, good interaction, and having that trust between the ICP and the surgeons, then only we can get compliance with whatever infection control practices or the preventive measures we talk about. Many of us, I am sure, in our day-to-day activity as infection control nurse or infection control professionals, meet intensivists or surgeons, right? And I know that they also work under stress. There are a lot of things of the patient care and the surgical technique itself which needs to be taken care of. Having said that, it is also imperative that there are certain protocols which needs to be followed, which are recommended by the IPCC for preventing these surgical site infections. Next. Yeah, you can put it in the chat box. Do you think SSI is a problem in your settings? Or you don't have any SSIs and it's perfect, everything is zero, there is no infection in your patients at all. If you think the SSI is a problem, then how big is the problem? Is it very huge, or do you think SSI is not a major part and your other aspects, maybe VAP, CLBSA, COTI, are more troublesome than an SSI? And do you calculate the surgical site infections in your patients? See, when you calculate SSI, please remember that it is specific to the type of the surgeries, like is it CABG or is it TKR, THR, or are you talking about neurosurgery? So you have to know what is the percentage of SSIs in your patients in that specific operation or in that specific department in your facility. Okay, now let us look if the Yeah, I think there is a question came up. That is the IPC Masterclass helping you in the, I don't went into the next field. Anyway, this is a question from my side. Please put it in the poll. As per the CDC, SSI is classified into how many types broadly? We'll maybe give you a few seconds, maybe 30 seconds. Please do the polling. One is done. What I think the polling can be seen. So the answer is superficial, deep, and organs. I'm very happy. So 70% of the people have categorized it into the 3 types, which are the broad classification for the surgical site infections by the CDC. Yeah. So let's move ahead. Next, please. So surgical site infections result in huge cost to the patient every year. If you look, the hospitalization of the patient is longer. Suppose a patient has come for a CABG and there is a surgical site infections. So what happens? You will have to make the patient stay longer. The patient cannot be discharged. You will have to see what type of organism is growing. Then you have to start on antibiotics. The dressings have to be longer. So sometimes patient might have to be in the ICU. So 60% of the time is spent in the ICU. And these patients, you know, the peculiar problem with the surgical site infection is it's more of a post-discharge also. It's not that within 5 days patients get infection. Patient might go home and come back after 1 week, 10 days, 15 days. So these patients come for readmission. So what happens if there is a surgical site infections? There is 5 times more likely that they come back post the procedure. Now, of course, with the advent of lot of antibiotics, awareness about the SSI, the mortality has come down. However, if you see some patients who are not able to come for a follow-up, it might be like all of us are not in the cities. Patient might have gone back to their villages and they won't understand what is happening. So such patient, and especially when there are comorbids, the patients might also have a higher mortality. Next. So it has been surveyed. See, the incidence varies from developed countries to the low and middle income countries. If you see that low and middle income countries, the incident rate ranges from 1.2 to 23.6. And the pooled incidence is about almost all 1.2 to 5.2 in developed countries. So there is huge variation depending on the type of country or type of economic status of the various countries. Based on that, the surgical site incidence also varies. So there are multiple articles. If you look at WHO, if you look at CDC, even from NICE, from the European journals, you will see a lot of the variations in the surgical site infections. Next. Yeah. What are the risk factors? Let's categorize it into 3. One is patient related, one is procedure related, and third is the proceduralist or healthcare worker related. So let's go to the next slide, please. Let's see what is the patient-related factors. So patient-related factors, all of us know age. Yes, very early age group or very older age group. Especially in India, we are seeing a lot of geriatric populations and most of them going for TKR, THRs and CABGs are the higher age. So higher age also the immune status is low. Nutritional status is very important. There can be very low preoperative serum albumin or there might be concurrent steroid use. Obesity plays a very important role. Then, of course, tobacco use, alcohol use. And in our experience, we have also seen that remote site infection. The patient might be having maybe a urinary tract infection at the time or a cellulitis at the time. And then patient undergoes surgery. There is always a chance of seeding of these bacteria and subsequently patient coming back to us with the surgical site infection. So nowadays, surgeons are looking also at the remote site infection, and with multi-drug resistant organisms, Candida auris coming up, the colonization also becomes an important patient factor which needs to be looked into when we talk about the preoperative factors. Next. If you look at the procedure related factors, so procedure related, shaving versus clipping, none of us are advocating shaving. It has become obsolete now, but it has been seen that if shaving and clipping are done, what is the rate of various SSIs, which I'm going to talk about in my subsequent slide. Improper pre-op skin preparation, because we have to look at what is the flora we are carrying on our skin, because the higher the bioload, the higher is the chance of the infection, especially at the incision site. Antimicrobial prophylaxis, wherever it is recommended, it should be as per the recommendation from the IPCC. If it is not, then again it becomes another risk factor for a patient. All of us know inadequate OR ventilation, OR traffic, all lead to a higher chance of surgical site infections in the patients. Let's look at the proceduralistic or the healthcare workers who can be responsible for a risk factor for the SSI. Next slide, please. So, surgical technique. Yes, surgical technique usually is not the reason for the development of surgical site infections. They are all experts. They come after lots of training. So most of the time, it is not the technique which itself causes the surgical site infections. Yes, there might be some lapses in the sterile techniques, instruments, as I was telling you about OR techniques or glove micropenetration. Behavioral issues, that is always there, and that also leads to a chance of a patient acquiring surgical site infections. Next, please. Infections can also come from endogenous, like I was telling, patients' own microflora. If it is something which is a lab surgery, or patients, we are entering into a gut or maybe a urogenital area, so endogenous infection can also cause. Staff in the operating room, there might be, like now we know that there might be people who might be a carrier for staphylococcus, or there might be having some other viral infections. So many of these times the staff in the operating room can also lead to the infection. Most commonly implicated is MRSAs. Contaminated dust and inadequate cleaning can also lead to the development of surgical site infections. Next, please. This we have done. Anyway, we have seen that superficial, deep, and organ space is the classification by the CDC. Next, please. So if it is superficial incisional, then it is the skin and the subcutaneous tissue. When it is deep incisional, then it will be fascia and the muscle. And when it goes further inside, that is the organ space. So you have to categorize it into superficial, deep, incisional, organ space. And why the categorization is important is, one thing is about the severity of the SSI. Second thing is also what could be the reason. It helps you in understanding. If it is superficial, is it because of the post-discharge dressings? If it is deep incisional, was it something which was immediate post-op? And if at organ space, was it from inside? Was it during the operative surgery where there something happened? Was it? So these are like intra-abdominal, ventriculitis, all these things. So this is how the CDC classification helps us in understanding the factors. Next. So when we look at the various factors for preventing of the SSI, we can divide it into before surgery, during surgery, and after surgery. So now I'm going to tell what are the pre-surgical or before the surgery, what precautions we can take. Next. Next, please. So pre-operative factors, the first most important thing which is of late coming up with lot of evidence is pre-operative antiseptic shower. Now, pre-operative antiseptic shower is important because our skin has lots of transient flora. That transient flora, even resident flora, that resident flora and transient flora needs to be removed. And in our experience, what we have seen many times, patients are scared to take bath. They are scared, okay, I have to go tomorrow for a surgery, so I can't, let me not take bath. I'll get cough, I'll get cold. That's a very wrong concept, because then we carry a lot of microorganisms in our body. In addition to the skin flora, sometimes we even see, especially patients who have been longer in the hospital, there might be some patients who are inpatients and going, they get colonized with multi-drug resistant organisms. Then what happens? If the bath is not taken, yes, you are doing a cleaning during the surgery, you are doing antisepsis, but it's only limited to that sterile field or incision field and maybe around it, but not the entire body. So pre-operative antiseptic showering becomes a very important part. I will be talking about it in subsequent slides, but I'm broadly categorizing what are the pre-op factors. The second thing is hair removal. Pre-operative hair removal is also something for which specific recommendations are there, and it should only be removed when it is required. If the hair is not interfering with the surgery, then hair removal has not been advocated. Patient skin preparation in the operation room. There are various antiseptics which can be used, and also antimicrobial prophylaxis. These are some of the things, and hand wash, surgical hand wash. These are some of the things which I am going to talk about a bit more in elaborate. Next, please. So first comes the bathing. Now, there are two schools of thought here. One is, there have been multiple studies. It's very debatable. You can argue with us also saying that is chlorhexidine or octenisan, anything is specifically required for the bathing. Now, as I was saying, that is to reduce the transient and the resident flora a bit. So, soap solution wash has also been advocated. There have been many studies. A few studies have shown there is a difference when you use chlorhexidine bath compared to just plain soap. There are a few studies who have not found any major difference. However, looking at your institute protocols or the surgical site infection rates or the type of surgeries you perform, you can take a decision, suppose for high risk surgeries like patients who are undergoing implants, like THR, TKR, and even some patients who are undergoing CABG. In such patients, you can have a recommendation to have a chlorhexidine bath. Now, this chlorhexidine bath, you have to give specific instructions. Many a times we don't give them instructions, so they will not know. The patients will just dilute it off and then take a bath. It's not like that. Two things we should remember is, first, it should not be applied above the jawline, because mucous membrane contact, head and all, ear ototoxicity, there are various factors. So above the jawline, chlorhexidine should not be applied. Similarly, in the genital area, it should not be applied. Rest of the areas it can be applied. So what you have to specifically tell the patient is to first with a normal soap solution, shampoo and take a whole body bath. After that, most of these solutions, what we recommend is 1 day prior and on the day of the surgery. So what you have to do, most of them have 100 ml solution. So take out 50 ml. Tell the patient to apply it on the whole body, as I said, excluding above the jaw and the genitalia, and let it remain for 5 minutes. After that, patient needs to take normal bath again. No need to apply again soap solution or any other solution. This has to be specifically told to the patient. At the same time, please remember, if the patient is allergic, if there are any skin conditions, if there is an eczema, if there is a contraindication, then you should not advise. So that is one of the things. So this really there are some studies which have shown, at least in high-risk patients, or transplant patients, even for transplant patients, like liver transplant patients, you can look at it. Then the rates of the surgical site infections have been shown to come down. Next slide, please. Make sure that these are alcohol-based CHG solution or plain CHG solution, depends whichever you are applying. Make sure that these things are, after taking a decision with the surgeon, these things are advocated. Next comes the skin asepsis. So skin asepsis, when I'm talking about, is during the surgery. Now, whenever during the surgery, again here, I will be telling that there are various solutions which can be used. It depends again on what sometimes surgeon is comfortable. Then if you are going by evidence-based practices, whether CHG with alcohol is the best, or plain CHG or alcohol with povidone iodine is the best. Again, these are the decisions which can be taken individually by the IPCC. There has been a recent article which has come out in the Lancet or also in the Nature, where they have looked at the comparison between various solutions which can be used during the surgery for the skin asepsis. Next slide. There is a recommendation both from CDC and AORN. So what first CDC says is that shower bath, as I told, the previous day bath and the same day bathing, and also the antiseptic skin preparation should be done from the center to the periphery. As we have seen everywhere, anywhere, it should be from clean to the dirty, right? So from the center to the periphery in the concentric circulation. This is from CDC. Next slide, please. AORN also recommends the same thing. AORN says that surgical site skin and the surrounding area should be thoroughly cleaned so that any of these transient and the resident flora is removed. Always make sure that it is a bit spreading beyond the incision site. It is not that I'm going to give only this centimeter incisions, I'm going to clean only that area. We have to make sure that it is spread beyond the incision area also. Next. Next comes the hair removal. So the recommendation which now has come out that you should not remove the hair unless it is required. It is not the patient is going for surgery, let me remove hair. Look whether that site really requires removal or not. Whenever there is a hair removal required, it's always advocated to use clippers. Because if you use razor, it will cause skin abrasions. The moment it causes skin abrasions, there can be contamination. The skin microorganisms can enter and it can lead to surgical site infections. And also, never ever allow the hair removal to be done in the OT. If it is done in the OT, again environmental contamination happens. So if it is done on the day of the surgery when hair removal is required, make sure it is done outside the OT complex and then the patient is taken inside. And never use razor, never use any of these creams which are available, but only use clippers. Next. This, as I already told you about the skin preparation. So you can use chlorhexidine with alcohol combination, or some people also use povidone iodine. Make sure you are aware of what are the solutions which are available for antisepsis. And povidone iodine, the percentage also, please look at it that it should be 10% for the skin preparation. So different for hand rubs, different for skin prep, different for the mouth cleansing. So chlorhexidine has different concentration for different purposes. Next. So surgical hand wash. Now coming to the other aspect. So we have already finished the removal of the hair, skin sepsis, and previous day bath. Now, if you see, surgical hand wash is also an important, most important in fact, the component of any infection prevention. And so it stands for the surgical hand wash also. What the APIC and CDC says is the first day, when you first case of the day. So as soon as you come to the OT, the hand washing should be at least 5 minutes, a surgical hand wash. Subsequent hand wash between the surgeries can be for 3 minutes. If you can see in this picture, there is a digital clock. Many a times when I've gone to some hospitals and have checked during my audit, what I have seen is they do not have a digital clock. If you do not have a digital clock, you will not know how many minutes you are washing your hands. And believe me, it makes a difference that you follow protocols of 5 minutes and 3 minutes. It's imperative. Now the rubbing of the fingernails with brushes and all has been removed. That concept is no more there now. It is a proper, all the 7 steps of the surgical hand wash to be followed, and it needs to be air dried. You are not supposed to put it under a dryer or anything, because these dryers do not have any filters and there is again chance of contamination. So it's always better. It is always recommended only to do a air dry. Next, please. WHO has a very good poster for that, where you can actually put it in your OTs to ensure that how the solution is taken. Many of the times now these automatic or sensor based dispensers are available in the OT. So either you can regulate it with your leg, or you can just put your hand below it and it has a sensor based one, and the puff of the adequate antisepsis comes to your hand, and then you can use it rather than pressing it and then like touching it with the hand every time. So now better methods are available, and the tap should always be elbow tap, so that washing can be done thoroughly, properly, and you don't touch the tap again, right? The concept is that you don't want to again touch after washing your hands. Next. Then important aspect of pre-surgical is also prophylactic antibiotics. Now we know that there is a categorization of the wound: clean, contaminated, dirty, infected. These are the different type of surgeries which are performed. CDC has very nicely defined what are the type of surgeries which we are talking about. And whenever we are giving a prophylactic antibiotic, go by the recommendation and antibiotogram and the antibiotic policy of your hospital. ICMR has also come out with very nice recommendations, various prophylaxis which can be given, but do discuss it with your microbiologist who will form this policy, because it varies. If it's a clean case, you usually don't recommend. If it's clean contaminated, most of the time, what are you looking at? You're worried about the skin flora. Unless it is something which is a devitalized or an infective wound, then yes, then it becomes slightly different. You are entering into an infected system. But Other times, what is it your worry is more about the skin contaminant, the skin organisms entering inside. So based on that, the recommendation of the antibiotic policy comes out from the Infection Prevention and Control Committee. It is important that it is given within 1 hour of incision. That is because you need to have an adequate concentration in the tissues on the serum. Only when it is something which attains the therapeutic concentration in the tissues a bit delayed, then it can be given maybe 1.5 hours, like something like a vancomycin. But other times we have seen that it should be given only within 1 hour. This prophylaxis tracking should also be done. Surgical antimicrobial prophylaxis about the antibiotic which is being used, appropriateness of the antibiotic, and the timing of the antibiotic. Many a times I see antibiotic is captured, but the appropriate is not captured. So these two things are very important. Whenever you have an SSI, look at what was the prophylactic antibiotic which has been given. Okay, so that is also a very important preventive strategy for the SSI. Next. I think OT decorum is something which all of us agree on as infection prevention personnel. I know I have to only talk about the pre-operative prevention strategies, but this has a huge impact on prevention of surgical site infections. OT decorum becomes a very important aspect post-COVID. I have seen people are coming up in scrubs from homes. People go about in scrubs outside the hospital, which is very sad. We have to ensure that the OT decorum is maintained. The theater attire is only for theater. Whenever they are going outside from the theater, the attire needs to be changed. There has to be a color code for the OTs. No jewelries. There should not be any watches, any jewelries when the OT personnel are going inside. And this stands for everyone. There should not be any longer fingernails or nail polish on it. And when we follow the PP, whichever is required, make sure that it is thoroughly followed. So OT decorum needs to be followed for prevention of SSI. I'm sure this will be dealt with when the second IPC class will be held on for the perioperative SSI prevention strategies. Next. So why we are worried about it? So the moment you open the door, I was telling about the OT traffic, right? Whenever you are opening the door, every time you are opening the door, there is a turbulence of the air, and whatever dust or whatever the shed skin, shed hair particles all fall on the floor, they get lifted. And if there is an open surgical field, then it can go and sit on the wound and cause surgical site infections. Next. Yeah, this I have already told about. The antibiotic has to be given within 1 hour of incision. Next. There is this very good article which has come out on prevention of surgical site infections, and this is for basically joint infection, prosthetic joint infections, prosthetic joint infections. So they talked about the 10 steps, which this is called 10-step approach, which talks about like optimization of the host risk factors. See, there are certain modifiable risk factors. There are certain which are non-modifiable. Which are non-modifiable, you can control. But which are modifiable, like hypoglycemia, normothermia, these are something which you can control. But if the patient is diabetic, you cannot remove the patient's diabetic status, but you can control the sugar. Similarly, optimization of the host risk factors, bioburden reduction, perioperative antibiotic prophylaxis, respect for soft tissues. So what is usually said, whenever you are handling, make sure that you are handling it with instruments, so not with your hands and separating out roughly the various tissues. Okay, and timing. There is an NNIS score, if any of you have looked at it, which looks at the type of surgery, the duration of surgery, and ASA score. If you look at these three, and there is a mark and there is certain point given to each, and based on that, you can look at the NNIS score. So one of the NNIS score point is also the longer duration of the surgery. If the surgery is longer duration, there is also more chance of infections happening. Reducing the blood loss, because blood transfusions have also been shown to higher risk for the SSIs. Operating room traffic, again, it's most important aspect. I'm repeatedly talking about it. Antiseptic irrigating solution. This can be used if there is a very devitalized and a dirty wound, which we are talking about. Sterilization of the implants and instruments, what we call about loaner instruments, which the company guys brings. So we have to make sure that instruments are sterilized, and wound management. So this is a very nice article. If you can access it, it's just available. Please have a look at it, and you can really put many of these SSI prevention strategies into place. Next. Tracking, I just briefly about the tracking. The SSI bundle checklist has to be followed. It will have, again, like same pre-operative, operative, post-operative. So these have to be done to prevent the infections, and this help you in ensuring there is a compliance with the bundle checklist. Next. Next, please. Yeah, so there is a CDC recommends there is an active monitoring, patient-based surveillance, prospective surveillance, and post-discharge surveillance. So the various methods for surveillance can be, the surgeon can call you up, then the ICNs or the ICT calls up the patients and have a follow-ups. Third thing is when the patient comes to the treatment room, you can have a follow-up and look at it, whether the patient is getting in any infection. And the fourth is from microbiology lab itself. So there are various methods for the surveillance. Next. Next is a polling question. So as per CDC, craniotomy requires how many days of follow-up? Is it 30 days, 45 days, 90 days, or 5 days? All of us who are in the ICP, I think it should not be a major. I think it is easy for all of us to answer, right? Let me see how many of you get the answer right. Very nice. So 90 days. So if you look at the NHSN criteria, you can go to the next slide. I'm happy that 65% people have told that NHSN it is 90 days. Yes, answer is right. Very heartening to see that a lot of people have marked 90 days. Next slide, please. Yeah, so this all of you, if you can, you look at the CDC, NHS, and when you look at the SSI recommendations, if you look at the last 4-5 pages, you can see this 30-day and 90-day surveillance has been given. Most of the time we think, okay, it's only implants and CABGs. It's not like that. It is even breast surgery. If you look at spinal fusion, craniotomies, even herniorrhaphies, these are some of the surgeries which require 90-day surveillance. So you have to define how long you are following. If it is not that, oh, it's 3 months is over, now no longer it's not my case of surgical site infections. So 30 days follow-up and 90 days follow-up is very important so that we don't miss this surgical site infection, because it is one of the toughest healthcare associated infection to track, in fact. Next, please. Yeah, and so you can have SSI tracking sheet. It is you can formulate based on whatever are the, is there a purulent discharge? Is there a pain at the site, inflammation, tenderness? So when the patient is in your hospital, you can have a SSI tracking. This is how we do SSI tracking in our hospitals. So SSI bundle is one thing, SSI tracking as long as patient is in the hospital, and subsequent when patient gets discharged, we follow the above mentioned protocols. So that brings me to the end of the presentation. And I have tried to limit myself to the pre-op preparation of a patient for the prevention of surgical site infections. I again thank Dr. Ranga, Reddy, IFCAI, and SANMED for giving me.
Thank you very much, Dr. Ratnamani. It is wonderful as usual. Such a brilliant topic and such a brilliant delivery on preparation of the patient for the surgery. Which happens to be the most important aspect in terms of our fight with HIs and our strategies to reduce the surgical site infections. I would not have asked for more than what is being delivered. Once again, I am extremely sorry for all the technical glitches and also my inability also to join initially. But Dr. Ratnamani covered for all the glitches. I think that is wonderful. As she very rightly mentioned that despite of all the efforts what we are making in IPC, still the SSI remains a big challenge. Even in tertiary care settings, even in most advanced nations also, this problem. Despite of all the efforts, it is still going unchallenged. And some of our own studies show that SSIs, especially in Indian settings, are sometimes even in the 2-digit numbers like 15%, right? Which is very unfortunate. And unless we are going to bring a change in terms of our attitude for IPC practices, I think, that is going to still going to remain a big problem. One of the best examples, recently I had been to Saudi Arabia, and there was this very big presentation done by Saudi colleagues. And also World Health Organization has really commended the efforts of Saudi colleagues, how they have taken up the challenge of SSIs, and over a period of 3 years, how they have drastically reduced the SSI prevalence in Saudi settings. If I remember well, I think, it was the reduction of almost like 40% during the period from 2021 to 2024. That's a phenomenal number. That means it is possible. It is possible if we have the right strategies in place, if we are going to take up, the right interventions at the right time with all the vigor. I think, it is very much possible to reduce the surgical site infections. In Indian settings, one of the things what has come to our notice is especially, cesarean sections, which are done in the secondary settings. They are actually causing a lot of increase in SSIs. So I'm sure, we would be able to work with the gynecologists and the folksy and other organizations in order to create a good awareness about the IPC practices what had to be there in the gynecology, apart from the general surgery and other surgical areas. If we are going to come together and, are going to put these interventions in right place, I'm sure, over a period of time, we will be able to achieve a massive reduction, because our base is very high. And from that base, we will be able to achieve a lot of reduction. Of course, today's topic in terms of chlorhexidine pre-surgical bathing, definitely, it is a gold standard. If you look at the Western countries, I think, it is considered as one of the best practices. And for somehow, I think in Indian settings, we are still not getting used to that. I don't know, maybe Dr. Ratnamani would comment on that. What are the reasons for resistance actually to move into the surgical, pre-surgical bathing? But I'm sure, over a period of time, we will get into that practice, and we will be able to get to that gold standard over a period of time. Without much ado, now let me open the session for the questions. I see, in the question answer box, there are multiple questions. Dr. Ratnamani, would you be okay to take a couple of questions, please?
Awesome.
Yeah. So the first question is CHG bath advisable for cath lab procedures? And maybe, you could also comment on my kind of question on why in Indian settings we are unable to get into the practice of pre-surgical bathing. Thank you very much.
Yeah, thank you, sir. And see, cath lab procedures, there is no specific recommendation. As I was telling you, when I was looking up at the literature, CHG versus plain soap solution. Most important thing is the hygiene of a patient. What we have seen in our various surgical site infections, when we're doing the root cause analysis, we found that many times the patient don't take bath because they are worried they'll catch cold, cough prior day, including head bath, even for a neurosurgery patient who is coming from elective surgery. So the basic thing is that there is a reduction of the resident flora. That is the reason we are asking for a bath. And it has been recommended more for CABG patients, though you can also look at maybe your transplant patients and THRT care. But as such, for a cath lab patient, proper soap solution bath should suffice. And coming to sir's question that why we are not able to introduce, I think one of the major thing is cost factor. Cost factor, unless it is available at a lower price. Like when even we were introducing in our hospital, we had to really struggle to make it like a package, something. And compliance. See, if you just give it to them, they will not know how to use it. So one is patient education. So we have to look at the type of patients who are coming to us. When we are talking to them, will they understand while I tell them? I'm giving them just a kit and saying take bath. They will not understand. So first is we have to give them from our side, either the surgeon at the time of when he's writing the surgical notes, what we tell is during prescription, please tell the patient that they have to take bath like this. So one factor is the acceptance by the patient that I have to buy this is one is the cost factor, and other understanding its importance. These were the two things which we found as a challenge in our setup when we introduced.
I'm sure they must be. And industry, make a note of what Dr. Ratnamani has said. Cost, bring it down so that every patient in India, every patient in global South can afford to get into the gold standard practices. SANMED, are you hearing? So
yes,
if you're
hearing,
please make sure that you are going to get at that price, which is going to be affordable for our patients. Second question, Dr. Ratnamani, for head and neck surgeries, what scrub do you recommend, or what pre-op bath you would recommend?
Yeah, so for head and neck surgery, CHG is not educated. One is because of the ototoxicity, second is mucous membrane. So plain soap solution shampoo is what? For neurosurgery, plain shampooing is enough. Even when we use CHG, we tell, that's why I was very specific to tell it should not be used above jawline. That's what is like, so that we remember that rule, it should not. So plain soap solution should be enough.
Absolutely. Yeah. And one more question is, chlorhexidine or povidone iodine?
Yeah,
I think it is a very difficult question. A lot of our guys keep asking. Please.
I actually had a few slides. I think somehow in this PPT it was missed, where I have put this was from, I think, International Journal of Infection Control, if I recollect exactly. So there was a lot of meta-analysis where they have looked at plain povidone iodine, chlorhexidine with alcohol, povidone iodine with alcohol. The major problem with alcohol is fire. Though they say it's a rare event, it can happen because many times cauteries are used. So unless you wait for the skin to dry, the alcohol combination is still not very easily accepted by the surgical personnel. Chlorhexidine versus povidone iodine, there has not been found major differences. They can use either povidone iodine or chlorhexidine. Having said that, one article, I think one or two articles have done meta-analysis where there is a minor change and there are minor difference and slight decrease in the surgical site infections when CHG has been used along with alcohol. Of course, the combination CHG has been used in compared to povidone iodine. But neurosurgery, gynae surgery, they still go in with the povidone iodine because as it's contraindicated. So most of us have shifted because of the persistent effect of the chlorhexidine. It stays almost for 6 hours after the skin antisepsis has been done compared to the povidone. So it is a persistent effect of the chlorhexidine.
Yeah, just to add on to what Dr. Ratnamani said, I think, there is a geographic kind of preferences. If you look at North America, it is mostly 99% it is chlorhexidine. You would rarely find pre-surgical bath with povidone iodine. If you look at continental Europe, somehow it is more of povidone iodine rather than chlorhexidine till very recently. But of course now even the Europe is more and more moving towards chlorhexidine because of the staining and other factors. But of course, at the end of the day, it is a question of what antiseptic you use is secondary, probably. Whether you are using it or not, whether there is a pre-surgical bath or not, that is most important actually to start with. Maybe over a period of time, we can develop our own evidence in order to move on to the ideal antiseptic, which we had to use for pre-surgical bathing. How do we improve the surgical hand wash compliance as I have seen many surgeons who do not follow all the steps of surgical hand wash? I think very difficult question, a behavioral issue. I think, Dr. Ratnamani must be actually breaking her head every day on this. She would be the right person to answer.
Yeah. So one thing is you expect surgical hand wash to be 100%. In all other areas, ICUs or what, yes, we do see the non-compliance and we keep on telling, but in surgical, you expect it to be, because that's what when you're going into a sterile field, you have to follow that. 3-4 things is, I think the surgeon, it is the integrity of a person. As you are saying, it's a behavioral, it's an integrity of a person. A surgeon has to do that. They have to do first case of the day, 5 minutes, next week 3 minutes. What another thing I have seen is like the introduction of leg and pedal used for the hand rub. Second thing is remote sensing hand rubs. So many of these things you don't have to worry about pressing it, and these are small factors. But see, you just put your hand and 2 puffs are coming, maybe you will be more compliant. So things like that. And of course, I know it's very difficult to talk to the surgeon, but that's why the IPC has to visit OTs more frequently. The presence of the infection prevention personnel themselves, they have that, okay, someone is looking at me. So the compliance improves. So I think it is these both the things. You have to provide them certain things so that they can easily watch. At the same time, the integrity of a person, both of them make an impact.
Thank you, Dr. Ratna. There are questions related to HEPA and all that stuff. I'm sure, in the subsequent sessions, you would get answers to that. So now probably,
there are some more questions in chat box also, sir. They have mentioned.
Yes. I see them. Are there any recommendations for pre-op MRSA screening? And what is recommended for pediatric population?
Yeah.
In terms of MRSA screening?
Yeah. So for pre-op screening, usually for CABGs, and they are recommendations. But again, as I say, in India, I think we still are dealing more with gram-negative compared to gram-positives. So there are recommendations. If you go at some of these, even WHO says that you have to look at the carrier status. I think it lies onus with your institute. What is your worry? Are your MRSA rates very high in post-surgical patients? If you are seeing there is an increasing trend, you can definitely look, because you have to also do decolonization. Is your surgeon going to wait for the decolonization for next 3 days? That is important. So I think you have to discuss with your infection control committee and have a protocol. Like for us, we have introduced for all our CABG patients, because axillary close to the sternal wound. So you are worried about the MRSA. So depending on at least high risk patient or high end surgeries, you can look for the MRSA screen. Look at your rates. Don't just go because some recommendation has come out. You might have to sometimes tweak these recommendations as per your institute trends. And pediatric population was what? What was the question, sir, for pediatrics? Sorry. So
there is another question regarding OBS-GYN. I think, it is very important because in Indian settings, we know that SSIs in OBS-GYN are quite high, right? Somebody is asking, what are the guidelines for prevention of SSIs in OBS-GYN surgeries?
So yeah, so though my hospital is not, OBS, but I can, whatever from my experience, I can tell you, see, it stands the same. Your classification of the surgery same: clean, contaminated, and dirty. Right. So are you talking about delivery, or are you talking about endometriotic surgery? Are you talking about any salpingo-oophorectomy? Depends on the type. So again, what is your worry? More and more now you're doing robotic and laparoscopy. I think gone are the days when you really used to do vaginal hysterectomies and all. So again, your worry is skin flora only. So when your worry is skin flora, you will give basically skin-related antibiotic prophylaxis. And post-surgical care, if you talk about prevention of SSIs in this lab, we have, I remember 15 years back like that, we have seen post-lap associated atypical mycobacteria, nocardia. Patient come back way later, 1 month, 6 months, 1 year, 2 years later with mild ooze from that port site. Unless you have a high index of suspicion that it can be a case of nocardia or atypical mycobacteria, then only you can diagnose. Then look at your lab instruments. So sterilization, disinfection of your lab instruments. So prophylaxis, disinfection, sterilization, and your post-op care, your dressings, how are they being done? When patient goes home, if they don't come back, Are you giving them specific instructions in their language? See, we should understand that not all know English or all know Hindi. So local language in bilingual, if they can give you a pamphlet saying ki they don't take bath. I have seen one patient who didn't take bath for 3 weeks and got pseudomonas because he was so scared. In spite of that, he got pseudomonas, if you ask. So tell them when they need to take bath, when they need to change dressing. If they are going for home care dressings, are you telling them to wash hands and then do home? So these are some of the things I think even it stands for, even if it's a gynop surgeries.
I think I totally agree with Dr. Ratnamani, especially when it comes to the communication with the patient. We should not have our preconceived thoughts or assumptions, especially the language barrier in the tier 2 or even in metropolitans. We should not assume that everybody would very well comprehend your instructions in English. So try and actually make them comfortable, give the information in their local vernacular language, so that you are certain that your communication is well understood, so that they can follow thoroughly on whatever you have instructed. Ma'am, what I have seen, especially when I was working in a rural setting in Andhra Pradesh, that when it comes to the C-sections, right, that is where you see a lot of actually SSIs, right? One factor, of course, is the hygiene, what you said. Some traditional understanding and thoughts that you should not take the shower and all that stuff. That is one part. Are there any other contributing factors? Is it the gynecologists and the obstetricians, who are also need to be trained in this area properly? Are they actually lacking it?
I think the basic thing is, as you said, one is surgical hand wash. They have to ensure sterilized instruments. Sutures, sometimes there is a chance that the sutures are used. See, we tell them once, if you are using certain suture material, then you just throw off. You do not reuse. I know in a limited resource setting that sometimes it becomes an issue. It goes for sterilization. Then you should have a very stringent protocol. And I think, see, that area usually has a lot of fat at that time. So it will be more of a stitch abscess rather than per se, I think, infection. So I think major breach will be the sterilization protocols in that. If there is a breach in the sterilization protocol and the bandages, which you come from the CSSD, those two things is what we have to look at when we are doing a cesarean section. That's one thing.
I totally agree. And, one more question is, can we use povidone iodine and CHG combination? Wow. I think, it is also a suggestion to probably the manufacturer.
I don't know how they will both interact with each other. I think we should not overdo. So plain CHG or Provident. Anyway, if you are recommending a patient to take a bath with CHG, and then you use a Provident, why do you want to use both of them at the same time?
Yeah. I think, all of us should be mindful also, overdoing does not actually bring better results. It may even harm. So let us not overdo it. And there are standards, which are already known. There are gold standards in terms of actually pre-surgical bathing, hand scrubbing, hand washing, so hand rubbing. So let us follow, what is the convention, rather than actually doing our own experiments and trying to be, holier than Pope, how they say, right? So how much more time we have, organizers? We have 1 or 2 more minutes to ask one.
Yeah, if the madam is available, then we can take up a couple of questions.
Okay. Maybe, one last question probably. It is related to the behavioral aspect. Surgeons do not on the hand hygiene timer before hand wash. What can be different alternative as a timer for hand hygiene compliance?
So,
is not working, whatever.
Yeah.
Behavioral issue.
Behavioral issue. So one thing is, of course, put a digital watch. That is the only thing. I have many times seen the normal watches, which will just move that handle, you will not know. So one is a digital watch, and have these audits See, you should have random audits on those areas. See, I know it is very difficult. So I put a slide. There is actually very nice slide where we say, I'm always right. If you have seen that slide. So that is a surgeon. I hope there is no surgeon listening to this. So they'll get angry.
There are surgeons. But you can be open, not a problem.
So what happens, I think it is a buildup of the trust. Say there might be. So first time you go and you have to tell them, I think if you go with a proper evidence-based, if you talk to them one-to-one, build up that trust, there should not be an issue. It might take some time. You have to build up that trust. First thing is that. Second thing is availability of digital. There has been someone was suggesting every, whenever they're watching some music should come and stop at the end of the 5 minutes. They are innovations. There can be done. But then how many people have access to that? Because we should not talk only about corporate world. We should also look at beyond people who cannot afford all those music-based systems. So I think first and foremost is put a digital clock there, have advocate compliance checks, do audits, and do one-to-one with the surgeon. It won't change overnight. It won't change, believe me. It will take time. That's why I put that slide also, behavioral. It will take time. But you should not give up. That's what we all do. We never give up. Show them the surgical site infection rates. If their rates are higher, show them that.
I think on that positive note, let us not give up. Let us, continue to enforce right infection prevention and control practices. And I'm sure, it was a great learning for me, as usual. Dr. Ratnamani's talk is always, something which evokes a lot of interest and also, a lot of knowledge and also takeaways from her talk always. I profusely thank her for taking her time to be with us and to deliver this wonderful lecture. Thank you, guys. Thank you all for joining us from wherever you are joining from, and have a safe time. Let us continue our march for the safer healthcare.
I would like to thank Sir Ranga Reddy sir for giving me this opportunity. Always a learning for me too. So thank you, sir.
Madam, thank you so much. Thank you very much for your time. And sorry for the initial glitches.
No
But
issues.
like they say, sabar ka phal meeta rehta hai. So we waited, but we had a wonderful lecture which has been concluded on a wonderful note. And the kind of questions and chat coming to it, it's very clear that the topic has a lot of relevance in the current context of IPC control, madam. The kind of questions which are coming up and the kind of queries they are coming. Still, I think there's a lot of area. I think our sessions, next 4 sessions also would be quite useful for the audience. And we promise you that next time onwards, we will be on dot with all the preparation. Again, extremely sorry for the delay in the beginning. And madam, thank you so much for bearing with us. It's a pleasure having you as a speaker. And like sir told just now, that it's always enriching to talk to you and learn from you, that you always put a right perspective to the whole matter without mincing words in between. That's what is the greatness of you. You don't try to mince words and keep anybody happy. You keep the subject as the most important thing to put it in practice rather than anything else. Thank you so much, madam. Thank you so much for your time. And thank you all for attending. Let us meet all again on next Tuesday, 3 p.m. same time. Thank you very much for the next session. Look forward to meet you on the next session. Thank you so much.
Thank you all.
Thank you, madam. Thank
Ganesh,
you so much.
and thank you, SANMED, and thank you, Ganesh, all your team for a wonderful session. Bye-bye.
Thank you, sir. Thank you very much, sir.